So she is an associate professor of pediatrics in the section of diabetes and endocrinology at the University of Oklahoma Health Sciences Center. Dr. Tryggestad holds the Paul and Ruth Jonas Chair in Diabetes and Endocrinology. She completed her medical school, pediatric residency, and fellowship in pediatric endocrinology at the University of Oklahoma Health Sciences Center. Dr. Tryggestad's clinical research interests are on the impact of complications in type 2 diabetes. She's a co-principal investigator for the NIH-funded T2D trial in Oklahoma and served on the Comorbidity Assessment Committee. Dr. Tryggestad's additional research interest is on the impact of maternal diabetes on the future cardiometabolic health of offspring and the impact of obesity and diabetes on vascular function. She has been awarded a grant through the NIH to understand the impact of maternal diabetes on microRNA expression and protein regulation in infants. Dr. Tryggestad serves as a provider to the Chickasaw Nation in Ada, Oklahoma. She also serves as the co-director of Type 2 Diabetes Comprehensive Clinic and as the director of the Turner Syndrome Clinic at OU Children's. Her clinical interests are focused on type 1 and type 2 diabetes with a special focus on Native American populations. So please welcome Dr. Tryggestad.
Thank you. Thank you, Dr. Raddick. Good morning, everyone. Ooh, that's a little bit loud. Okay, we'll do our best. All right. Well, I am thrilled to share with you some of my passion today, especially with type 2 diabetes. Some of the, okay, let me go back over here. There we go. I don't have any disclosures. However, I will be talking about medications off-label because this is type 2 diabetes in youth and we just don't have medications. So we're going to be talking about that. I will try to point that out as we get closer. So what I want to kind of bring together today is to look at what are the trends in diabetes and kind of refresh our minds about that. And then looking at the progression of diabetes with the new ISPAD guidelines that came out kind of in the fall. I also want to look at kind of treatment and kind of some of the changes and some of the things that we've kind of at least wanting to rethink about how we treat type 2 diabetes. And then one of my greatest passions is complications. So we're going to look at those, especially as they were, we found out from the T2D study. So kind of identifying some of those gaps. I think we frequently fail to intensify treatment in type 2 diabetes in youth at an early enough stage. And as well as recognize that these complication rates are very high, that we need to start addressing them at diagnosis. So let's look at some of this prevalence data. Now, a lot of this comes from search, and we're very familiar with the search data, but this is again looking back from about 2003 to about 2015 at the incidence, the new cases in type 1 diabetes and type 2 diabetes per year. And we can see that there is an increase in type 1 diabetes. However, the increase in type 2 diabetes is at a more rapid pace than type 1 diabetes. And if we drill down a little bit more into that type 2 diabetes, the incidence, the new cases is not static when we look across ethnic minorities, and we see that there is racial disparities. When we look at this, specifically Native American, American Indian youth, Hispanic youth, their rates of type 2 diabetes are rising at a much more dramatic rate than the non-Hispanic white. You can see a little bit of variability with the Asian Pacific Islander. I can tell you that there is a slight increase there. That's not showing up. Okay, well, we'll do it this way. A slight increase with the non-Hispanic Black population again, but again, drawing your attention to the dramatic rise in both of these two groups. Now, hot off the presses as of December, this was looking at, again, from search data, trying to make some predictions as to what would be what would diabetes look like for type 1 and type 2? What would be the burden by the year 2060? So they were looking at prevalence. So this is how many cases in total in 2017, and then the incidence. So how many new cases developed between 2002 and 2017. And they looked at it by diabetes type, by age, sex, race, ethnicity. And so the model that they were looking at was, okay, between the no diabetes, what's the incidence? What's the new cases of diabetes developed? And then within that, trying to take into account mortality as well. And then they looked at two different models. So one in which they would say that there's a constant incidence, so that the incidence between 2017 to 2060 was the same. So it's a static model. And then they also looked at a model with increasing incidence, so that looking at the increase that was seen between 2002 and 2017, putting that into a model of what would that look like if that incidence continued. And what they were looking at, so this is from 2017, you can see the number per 1,000 in cases of type 1 diabetes and type 2 diabetes. And then that little box there here shows the constant incidence. So this was the same as in 2017. You see that there are about 191,000 for type 1, 48,000. So again, the increase in type 2 was about 70%, but still significant. When we look at that in an increasing incidence model, so that it's not static, but continues to increase with time, we see that yes, there's a dramatic increase in type 1 diabetes, so about 65%, but a 700% predicted increase in type 2 diabetes in youth. That's alarming. That's incredibly alarming, given that we currently have a struggle in how to adequately treat this population and prevent type 2 diabetes in youth. So knowing that, we will look briefly, and this is some of our data here from the center in Oklahoma. We went back and looked at our data from 2011. I will put the caveat there that our 2022 data probably isn't quite complete, so please don't think that we had less, because I can guarantee we didn't. But when we looked at that, so our increase from 2011 to 2021 was about a 6% increase. So it was about 100%, 106%, sixfold. Our increase in type 2 diabetes was 140% from 2011 to 2021. And then the increase in type 1 diabetes was about 81%. So again, a lot of we definitely have had an increase in the number of people presenting to our center with type 1 diabetes, but the number with type 2 diabetes is almost twofold higher. So again, we have a significant problem in Oklahoma as well. So we've got a problem. What do we know about it? So I'm going to go into some studies right now. And one of them, of course, is near and dear to my heart with today's study. And I know that we've shared some of this data throughout the years. So this is going to be a quick recap. But again, today's study was the largest study to try to look at what was the best treatment in type 2 diabetes in youth. So there were about 699 individuals across 15 sites. Oklahoma was one of those sites, and we were the largest site. Which I will briefly mention that was really due to our partnership with our Native American partners. We would not have had the success that we had in that trial without the partnership that we had from our tribes and nations here within the state. So again, this was the primary outcome. So primary outcome in today's study was hemoglobin A1C greater than 8% for at least 6 months, or the inability to wean from insulin therapy after a metabolic decompensation. And our treatment arms were either metformin alone, metformin plus rosiglitazone, which still is not approved in youth, and then metformin plus an intensive lifestyle intervention. When I say intensive, this was people interacting weekly and then bi-weekly. I mean, it was very intensive. They were going to their homes. This was an effort to try to make a difference. And we saw there that really what was the group that did the best was the metformin plus rosiglitazone, and that was superior to the group that received metformin alone. There wasn't much difference in the metformin and lifestyle compared to metformin alone or compared to metformin plus rosiglitazone. What we kind of looked at this, as you can see there, that the 46, almost 47% had a primary outcome. So they failed treatment within the first 6 years of the study. So very rapid progression of their disease and inability to maintain on a single agent, especially glycemic control. And we looked at, okay, so why? What's going on? And we were able to look at kind of surrogate markers for beta cell function using an oral disposition index. So this is taking into account insulin sensitivity. And we kind of plotted this in those patients that did not fail. So that's there in the blue line versus those that did fail. And what we see is within 6 months of being in the study, there was about a 20% reduction or 20% drop in their oral disposition index in those that eventually went on to fail. And so really, it wasn't insulin resistance, it was their beta cells that were failing, and trying to find a therapy then to preserve beta cells, to preserve this beta cell function, leads to the next study, which was the Restoring Insulin Secretion in Pediatric. There's an adult version of this study and then the pediatric version of this study. And the whole goal was to try to find a way to preserve beta cell function. So these were youth. They were either, all of them were obese. They either had impaired glucose tolerance or were relatively newly diagnosed with type 2 diabetes. So there were, for the youth, there were 2 intervention groups. For the adults, there was also a GLP group. GLP at this point was not approved in youth, so we couldn't get that arm of the study. They were either on metformin for 12 months, or they received a run-in period with 3 months of glargine followed by metformin. At the end of 12 months, there was also a 3-month washout period. And then they wanted to look specifically at beta cell function. So this is one of those figures from the study. And so this is looking at, this is the C-peptide, steady state C-peptide there on the y-axis, and the x-axis being measures of beta cell function. So you can see there the kind of brownish color is the metformin only group. And so they did fairly well. I mean, there's a little bit of change there at 12 months, but pretty dramatic decrease in beta cell function after that washout period. When we look at the group that received glargine first, already at 12 months, they had a pretty significant decline in their beta cell function that really was no different there at 15 months. When we look at their maximal response, so these were on IV glucose tolerance test, a huge bolus of glucose, trying to get the maximal response from the beta cell. You see there at 12 months, regardless of the therapy, there's a significant decline in the amount of insulin that could be made by the beta cell. So significant beta cell failure within 12 months. So again, pointing out that it is very important for us to preserve the beta cell, but we don't have the answer yet of how to do it. So let me kind of move now to these ISPAD guidelines that just came out. And these, again, are going to focus on type 2 diabetes. So they've kind of broken it down into 3 different categories. And these are really primarily based on A1C. And I know we've kind of talked over the weekend that maybe A1C, there's variability, there's, there may be some other indices, but right now we're using A1C. That's the best that we have. And so if you have an A1C less than 8.5%, it is recommended that you begin metformin therapy, titrating up to the maximum dose, 2 grams per day, as well as lifestyle interventions promoting healthy diet, promoting physical activity, based on the guidelines that we heard yesterday from Dr. Whedon. And then there's the group that at diagnosis, their A1C is greater than 8.5%. So again, you do the same thing, but at that point, it's also recommended to start basal insulin. And the initial dose there of being 0.25 to 0.5 units per kilo, and that can be actually titrated fairly rapidly to get good control. Now, if they present in HHS or acidosis, absolutely, they need they need IV insulin to clear the acidosis, and then at least sub-Q insulin to help clear the ketones along with their healthy lifestyle. And of course, we wait to start metformin until their acidosis is resolved. Now, after that month, and initially when we're at diagnosis, of course, we get antibodies on everybody. Because we all know that there's an epidemic of obesity, and we can't tell sometimes looking at the patient whether this is type 1 or type 2 diabetes. But if their antibodies are positive, they need to continue on sub-Q insulin in a basal bolus fashion, and probably be reclassified. That's what they're suggesting there. And we would say the same, that if they have positive antibodies, they need to be classified as a type 1. Now, if their antibodies are negative, of course, we want to continue metformin, the goal being to try to wean them off of their insulin. And again, considering other agents, because now we do have approval of GLP-1 agonists, and we'll talk about some of the therapies here in a minute. And we know, or we presume at that point, that we're treating type 2. I will put in the caveat that sometimes there might be a MODY hidden in there. We've seen that sometimes, but again, looking at family history there. And so after we've kind of delineated that, yes, this is type 2 diabetes, what are our goals? The goal being to try to get the A1C as low as possible. That's really the goal for this group. And so if they are able to have an A1C below 6.5%, we're going to keep them on metformin. We're going to encourage their lifestyle changes and continue to try to wean them off of insulin. As I tell my patients, insulin is an anabolic hormone. It is contributing to weight gain. So while you need it, if we can make some other changes, help you with other ways, and we can at least back off on the amount that is needed, that would be wonderful. Now, if the A1C is in that 6.5 to 9 is the new ISPAD guidelines here. Of course, maximizing metformin, again, add GLP at that point. And then it also says consider other anti-hyperglycemic medications. When we're considering that, basically it's meaning thinking of off-label therapies. Because past a GLP-1 analog, it would be considered off-label in youth. And then if your A1C is continuing to be above 9%, then of course, if you're not on long-acting insulin, that needs to be initiated. If you're on it, increasing the dose, and again, trying to add whatever other medications that we could possibly add to try to improve their overall glycemic control. So these are kind of the new guidelines. I think one of the big changes, and from talking with my colleagues with different at different centers across the nation, is actually you notice there that it just says initiate long acting. It doesn't say initiate basal bolus. There are very, very few centers that are using bolus or rapid acting insulin in type 2 diabetes outside of an acute decompensation. Again, because it's anabolic, because it's contributing to weight gain, and there's pretty low compliance as well, to be very honest. So trying to maximize other therapies and using a basal bolus system is an absolute last resort. So talking through that, let's talk about some of the treatments. Okay, metformin. Metformin's our standard, and really still is the initial treatment for both adults and youth. With type 2 diabetes, as we said, it's the first line therapy, should be started on everyone. Of course, we want to make sure their renal function is normal. And like we usually wait until after they're out of the hospital setting to start it if they have come in acidosis. And then, of course, if they're over the 8.5% when they initially present, we will add a long-acting insulin analog to that. And then, of course, we start, and the biggest side effect for metformin, of course, is the GI side effects. And so we have to counsel pretty extensively on, there's maybe some nausea, there will maybe some diarrhea, but if we can push through, this will improve. And so starting them on 500 and then slowly titrating up over several weeks to 1,000 BID. And then just kind of briefly, again, focusing down here on the bottom of the slide, what does metformin do for us? It will help here with the within the intestine, trying to reduce glucose absorption. It will also increase glucose utilization. Within the liver, this is a huge benefit for us because we can decrease glucose production there. And of course, glucose utilization, especially in the muscle and the adipose through various mechanisms as well. But as we saw in today, it has its limitations. And we saw that within 2 years, about 48% of the youth were not able to maintain glycemic control. When we look at they were actually, like we said, more likely to require additional therapies, and that again, there was huge failure rates. Search saw similar results in that even at 2 years after diagnosis, about half of their patients had an A1C greater than 50%. About 50% of those required insulin therapy. So again, we see that in this particular population, it's not a durable control. So we now move to the GLP-1 agonists, which are, at least we have some that are available in youth. So this is hormone normally produced by the small intestines, and it helps with insulin secretion and will inhibit glucagon, which are both helpful. It will actually slow gastric emptying. So this helps some with the satiety as well. And then there are some shorter acting ones. However, the longer acting ones may be a little bit more effective with fasting glucose. So what are the studies that we have? In youth, we see that they will reduce the A1C by somewhere around 0.5%. At least in some of them, we see that it will lower fasting glucose. I'll put the caveat here that in a lot of the youth studies, we don't see the weight loss that we see in adult studies. And that's one thing that's been pointed out several times. However, and we'll get to this here in just a second, like liraglutide uses a daily injection. However, the liraglutide preparation, the Saxenda that's approved for obesity, is almost twice the dose. So at a much higher dose, we can see the weight loss. Exenatide, which is a weekly preparation by Bydureon is what it goes by. That one's also approved. Semaglutide goes by the trade name Ozempic. It has very recently been approved under the trade name Wegovy for weight loss. So it does not carry a type 2 diabetes in youth indication yet, but does carry the weight loss indication. And again, is at a higher dose than what has been tested in glycemic control. And then dulaglutide, which I'll bring up the study here in just a minute, at least, has been studied and does show some promise for glycemic control. So the LIPS trial was kind of the pivotal liraglutide study that led to its FDA approval. This was added to metformin, and then they could have basal or insulin if they needed it based on their control. And these were in patients 10 to 17 years old. They were randomized 1-to-1, double-blinded study, and they had to be obese. They were looking at A1Cs between 7 and 11. And then the primary endpoint was, of course, their change in glycated hemoglobin, the secondary being fasting glucose. And then, of course, they look at safety. So what they saw was in liraglutide at the high dose, the 1.8 milligrams, and there was improvement in glycemic control. And the higher dose, which improved glycemic control, there were more GI side effects. And again, in the ELLIPSE trial, there was a trend toward weight loss, but it wasn't significant. So when we look at the exenatide trials, and these patients either received placebo or the exenatide, again, looking for change in A1C with secondary endpoints, being kind of safety, things like that. And 83% participants that you can see that there's some dropout there. Again, we see GI side effects with these. So we did see a significant decrease in the exenatide group in their A1C versus their control. The fasting glucose wasn't significant, but it did kind of trend that way to be lower. And of course, the side effects being GI were the most common. So it did prove effective and was approved for use. Now it is nice of the two approved that the exenatide is weekly, so that does tend to improve patient compliance. So that's always helpful. The thing that we have noticed within our system is that because exenatide is in a higher tier than liraglutide, they have to try liraglutide and fail it, and then can move to exenatide. That's been kind of our experience. So then looking at the dulaglutide, so this is the Trulicity. So this was also double-blind study, randomized 1:1:1, and that was metformin alone, and then with and without insulin as well. And looking at a couple doses, and I can say in adults, there's actually quite higher doses than what was in these initial tests. And again, that we saw that it showed glycemic improvement, but again, at these doses, which again are lower than what we see in some of the adult studies, there wasn't an impact on BMI. And so that's kind of the ongoing question now is what dose should we use? Because we can achieve glycemic control, but should we push these doses to also help with BMI? Right. Okay, and of course, reviewing quickly the long-acting insulins, of course, we have Detamir, Glargine, Degludec, and I've pointed out the rapid-acting insulins, but as I was mentioning a moment ago, we seldom will use those outside of an acute metabolic decompensation now. I can tell you from our clinic and our experience that in these highly insulin-resistant patients, Levemir doesn't work quite as well. We have to increase the dose. We frequently have to go to BID dosing, which again creates issues with compliance. So we, especially in our youth with type 2 diabetes, have kind of trended away from using Levemir and using more Lantus and the Glargine, using more Degludec, especially because Glargine and Degludec also have the ability to have concentrated insulins. And with insulin, of course, the recommendation is to start there, and we usually start at about 0.5 units per kilo per day. That's rapidly titrated up to 1 unit per kilo per day, 1.5 units per kilo per day. So within those doses, that can easily become 150, 180 units of insulin per day. And having the ability to have concentrated insulin at that point is huge. Helps with absorption. That way they're not giving such a large bolus at one time either. So that's kind of been our experience with that. Moving on to the medications that we've seen in adult practice, but again, not approved in youth. And so the SGLT2 inhibitors hold promise, and we have empagliflozin, canagliflozin, and dapagliflozin. From adult data, there's been a lot of cardiovascular benefit to these medications, and we just coming out of the lipid lecture, we're hopeful that that will hold true for our youth as well. And then, you know, the thiazolidinones, the TZDs, we used rosiglitazone, and today we saw that it was effective. They've been around a long time. And the other benefit for lots of my patients, they're cheap. and they do work. So talking really quickly about the SGLT2 inhibitors, and these are the sodium glucose cotransport within the GI and the kidney. The specific one in the kidney, which is the SGLT2, works in the proximal tubule. So basically you pee out your glucose. And this works as long as you have appropriate kidney function, appropriate GFR. And so if you have GFR impairment, this may not be the best medication to choose. And especially, we're seeing CK3 or higher. Now, looking through, as I mentioned, of course, the primary being that we have increase in your glucose excretion, decrease in the absorption. And what we know then that's going to decrease plasma volume, so that will help with blood pressure, decrease the filling there at the heart. And so the idea being that we have better cardiovascular outcomes. And there may also be some effect with the sympathetic activity, as well as, the main thing being, yes, we hope that we have improvement in glycemia as well. So there have been studies, dapagliflozin, I'm pointing out is one of these, and this was a trial that was done across multi-centers, across multi-countries as well, looking at kind of the adolescent emerging young adult population and randomized 1-to-1. Their primary outcome being what was the change in A1C. And then, of course, what did they see? There was initially not a lot of difference in the A1C in this particular population, but when they looked at it a little closer and tried to look at those who are truly compliant with the medication, they did see a significant difference in their A1C. So, and did show that they were fairly safe without significant hypoglycemia. And so again, compliance, this may be a really excellent addition to our armamentarium for treating type 2 in youth. T2Ds really quickly, of course, pioglitazone is insulin sensitizer, and we sometimes use this if they're not able to tolerate metformin. And there does seem to be some improvement in steatosis and fibrosis in those patients that also have NAFLD, so kind of a benefit bonus there. And when used in combination with some of these other medications, especially the SGLT2 inhibitors, the side effect of fluid retention and weight gain may be helped. Again, like Dr. Wilson is saying, we're having these conversations about off-label medications. We document this thoroughly in our note that we've discussed this with our families. But the fluid retention, the weight gain is one thing that we talk about, but can be mitigated if we're proactive. And so again, and today we did see that the addition of rosiglitazone to metformin was very helpful in glycemic control, especially in some of our female patients. So something at least to consider. There we go. Okay, so moving on out of the medications into complications. So as we mentioned, the first phase of today was looking at treatment therapy. The observational phase of today that followed was looking at complications. And so what we saw in today was that the cumulative incidence of microvascular disease over about the 15 years of the trial was 80%. So started out with a baseline prevalence of about 9%. At the end of the trial, and this was any microvascular disease, by the end of the trial, 60% of our participants had at least one microvascular complication. And some of the things that predicted who was going to develop microvascular complications, there was some effect of race ethnicity, which you can kind of see there in the top. I'm sorry that's a little darker than I had hoped. And then there are definitely glycemic variables as well that contributed to their risk for microvascular complications. So you can see that A1C had some effect, but hypertension, dyslipidemia, those other comorbidities also played into there. And their insulin sensitivity in the model of complications also was predictive. The more insulin sensitive they were, the fewer complications. We also looked at those that had more than one complication, so the clustering of these microvascular complications. And right there in the very middle, you can see the 48. There were 48 participants that had nephropathy, retinopathy, and neuropathy. So they had all three of the microvascular complications by the end of the trial. And I failed to mention this on the other slide. The average age at the end of the trial was 26 years. So very rapid progression of complications in these youth. And, we're thinking their duration of diabetes on entrance to the study was about 8 months. So this is within, 12 to 15 years of their diagnosis that we're already seeing this. Very similar to what we saw with whether they were going to develop a microvascular complication or not. The clustering, the development of more than one microvascular complication was also predicted somewhat by race, ethnicity, as well as other glycemic markers, and significantly by hypertension and dyslipidemia. If they only had the one complication, they developed that around 6 years into the trial. If they had two, their first complication was at about year 4, the second one at about year 10. And for those 48 that developed, sorry, I'm getting a lot of feedback. For those 48 that developed all three complications, their first one happened around year 2, 3, the second around year 7, and then the third around year 10 or 11. However, you can see that there are outliers, and this particular person had all three complications within 5 years. So again, very significant complications. As Dr. Raddick was mentioning in the introduction, I had the privilege of serving on the assessment committee, because beyond collecting just nephropathy data, we collected records on all of these youth looking for cardiovascular complications. And while I didn't put it up here, we also looked at the deaths. And so we did have it in the study. We had 5 deaths, one from an MI, one from renal failure, and then of course, one that ended up with renal failure secondary to sepsis. And then of course, some other things that we see in this youth. But I can also tell you from being one of the primary adjudicators for cardiovascular and cerebrovascular events, we had 3 patients that had 4 MIs. We had 3 patients that had 4 cerebral vascular events, and we had 8 that had congestive heart failure. So again, this is a big concern, a very big concern. So kind of wrapping up now, I want to talk really briefly about what should we be screening for? This is again coming from those ISPAD guidelines. So of course we screen for hypertension, and we should do this at every visit. Dyslipidemia, again, at their diagnosis, this should also be screened annually. Again, says fasting lipids. I tend to agree with Dr. Wilson. If we can get them, we get them, because especially with this population, trying to get them coming back for labs is a significant challenge. So I go plus and minus on the fasting at least. Their nephropathy at diagnosis, and then yearly NAFLD at diagnosis, and then yearly using the liver function test. Obstructive sleep apnea, we don't think about that, but I think like Dr. Fisher was saying, now there is some reimbursement, there's some coverage for this. We need to be sure that we're screening from that, especially from a cardiovascular standpoint. For the females, screening for PCOS. For retinopathy, it needs to be done at diagnosis, and then yearly neuropathy as well. And so what we should be looking for are symptoms there. It's pointing out the pain and numbness, but also testing for vibration and especially ankle reflexes. And I know that that's something that we're trying to incorporate and do better in our clinic, to do that on an annual basis. Psychosocial health. Diabetes is hard. Diabetes distress is real. So trying to screen at diagnosis and then every encounter, and is tied with that the social determinants of health. So it's we're in the process of trying to develop a screening tool so that we have a better understanding for the food insecurities that are present in this population so that we can begin to try to address that. And of course, smoking and preconception. I also served on the as the writing group chair for the pregnancy outcomes in this study, and we had 141 females within the study that had at least one pregnancy. And when we were looking at that particular group, there are about 35% of the participants that had some sort of extended hospitalization. And about 12% of the pregnancies resulted in a cardiac abnormality. Because the vast majority of them had an A1C greater than 8% sometime during their pregnancy. So when we ask how many had any preconception counseling or contraceptive use, it was in the neighborhood of 13%. So something that, again, we have to do better with. So really quickly, again, the hypertension, we want to do that at each visit. And of course, starting initial treatment if they're above the 95th percentile for height and weight. And it's 6 months that continues. We want to be sure and start ACE inhibitor as the initial therapy and trying to treat to less than the 90th percentile. If they don't tolerate the ACE, and we do have some that have a cough, and looking at the ARBs and angiotensin receptor blocker, maybe an alternate therapy. And it may take and we see this, it may take combination therapy to achieve appropriate blood pressure control. And if we don't get a lot of response from the medication, that's when we may need to look a little bit further and make sure that we don't have renal artery stenosis or something like that complicating the picture. Albuminuria, and I will point out that the nomenclature has recently changed on this. What we used to call microalbuminuria is now moderately increased albumin excretion, and that's the 30 to 299 milligrams per gram. And then severely increased albuminuria is now the term that has taken over for macroalbuminuria. And again, we see those elevated, so we want to be sure that we look at 2 out of 3 consecutive measures. And then we can begin treatment. And of course, ACE is the treatment for that as well. And then should be repeated to make sure that we achieve a normal level. And of course, titrating therapy if we're not reaching that goal. And we have to exclude the others, and especially if they have the severely increased albuminuria, frequently we'll at least send them to nephrology for a quick referral. And so this is, again, the lipid guidelines. Dr. Wilson has pointed out a lot of this is already, but again, with our group, if we try lifestyle intervention at first, but if they continue to have elevated triglycerides or continually elevated LDL, it stays above 130, we want to start statin therapy with their continued dietary interventions. Their triglycerides remain over 400, then considering a fibrate for sure. And if they've made those goals, maybe we can continue just with their therapy. So in conclusion, I hope I've impressed on you now how aggressive type 2 diabetes is in youth. The complications happen very early. There are deaths at a very young age. And that this increase in beta cell failure over time, we need to find new therapies to preserve beta cell function and be able to predict those early on who are going to have this significant decrease in their beta cell function. There's actually a new study that's developing to try to better define those. One of my other passions is what is the impact of maternal health, maternal diabetes, maternal obesity. Some of these interventions may have to come at the preconception age to be very effective. So with that, I will close, and I thank you for your time.
Thank you, Jeannie. That was an amazing talk. And I think you mentioned several times the issue of compliance with this population. I think we all struggle with that. And definitely there's an issue with the insulin, but I know it's all new, but with the GLP-1s, do you find that your patients tend to be more compliant with that type of therapy versus, insulin or metformin, lifestyle?
So the more simplified we can make the regimen, the more compliant they are. So going with a GLP that is weekly greatly improves compliance. Like we're saying with the insulin, trying to do something that we can do once a day rather than twice a day improves compliance. To be honest, many of the off-label medications like the SGLT2 inhibitors and the TZDs that you can take once daily rather than twice daily metformin have proven more beneficial because somebody's agreeable to take one pill once a day. So we'll kind of see as we go on, but I think getting to the compliance, simplifying the regimen, and as far as the lifestyle, trying to meet them at their level. Dr. Jeter is our psychologist and does a fabulous job with motivational interviewing and trying to find, okay, what are you willing to change today? And we just try to build on that of what is the one thing that you're willing to work on that's important to you between this visit and next visit. Sometimes that is an activity goal. Sometimes I'm going to eat breakfast or I'm going to not have Sonic 5 times a week. So just trying to build on those little things that they can identify and trying to personalize it as best we can. And there actually are no virtual questions, at least that I can see.
The audience, anyone have any questions for Dr. Trigastad? Okay, well, I think it's nobody.
For the hypertension piece, how much of that is attributed to, a white coat syndrome, uncomfortable situation? How many readings of hypertension are we looking for versus like, when are we getting a renal ultrasound?
So we always repeat with a manual blood pressure before we leave. And that's the one that I tend to go by. If that one is still elevated and it's been elevated for at least 6 months, then yes,
Okay.
they need to be treated.
Sure.
Now, as far as the further workup, that will depend on how they respond to treatment. If we're not able to make progress with their, especially their systolic blood pressures on ACE or maybe ACE and ARB, those need further workup.
Okay. Thank you.
Anyone else have a question for Dr. Trigastad?
I think Dr. Dossery did.
Thank you, Dr. Trigastad. That was a wonderful presentation. I had a couple of questions. One, you mentioned that if it is antibody negative, then you try the GLP-1 agonist, but we are limited to just 3 in common practice, just testing 3 of the antibodies. With the increased prevalence or incidence of obesity, I should say, there are quite a few type 1s that I see in my practice that are obese. Antibodies might or might not be positive, not maybe early in the stage. What can you comment on GLP-1 agonists and metformin use in that population? And I know it's out of scope of your presentation right now.
If they are truly antibody negative, we'd go ahead and do a trial of metformin for sure. And usually we have to try that and then we can move to the GLP depending on insurance. Some insurance will let us go directly then to GLP. But especially if they're showing outward signs of insulin resistance, the metformin is still going to be at least some help potentially reducing their insulin dose.
Well, thank you. And then you said failure of liraglutide before you move on to the next one. How do you define that failure? Like, I know it's insurance that's telling you what to do, but.
So I've defined it a couple of different ways. If there has been no change in their A1C, I consider that a failure because it was an adjunctive therapy and it did not decrease the A1C further. For some of those, I have also tried and said, okay, we actually have had weight gain on this therapy as well. And so we'll try something different as well. Most of the time I try, especially for insurance, try to tie it back to some glycemic target, either that the A1C is increasing or that it did not change. And that was the goal of treatment.